Hi there, I'm Rob Gross. I'm speaking for the Spring Education Summit for the Rocky Mountain MS Center. Today's topic will be updates on MS disease-modifying therapies. I don't have any relevant disclosures for today's talk. So this year has been, well, the past 12 months have been pretty exciting for the field of MS in terms of immunotherapies. We've seen the arrival of several new FDA-approved therapies for multiple sclerosis. There's been siponimod, which is also known as Mayzent, ozanimod, known as Zeposia, cladribine, the trade name is Mavenclad. And in addition, there's been the introduction of several generic versions of fingolimod. The trade name for that was originally Gilenya. As well as a new fumarate, diroximel fumarate, which goes by Vumerity. So a number of new therapeutic options in our armamentarium. You may notice that many of them are fairly similar to medicines that we have at the moment. So for instance, siponimod and ozanimod are in the S1P receptor category, and I'll talk a little bit more about that in a second. But those are that's the same class of medication as fingolimod, which has been around since 2010. And in addition, diroximel fumarate is a fumarate like Tecfidera as well, which is expected to act in a similar way. Cladribine is a different type of medication that has actually been around in a different form, in an IV form previously, but just received FDA approval in an oral formulation. And it basically acts to reduce T and B lymphocytes in a way kind of like a chemotherapy. It's given in courses of several days and then spaced out by a month, and then there's another course a year later, and there's a cumulative amount that you can take because there's a risk for malignancy with that one. The others, siponimod, ozanimod, fingolimod, these are all once daily oral medications, and diroximel fumarate is a twice daily oral medication, like their predecessors in their respective classes. Moving on. Coming soon, we have additional medications that hopefully we'll see in the clinic, but are not yet FDA approved. So we have ponesimod, which is another S1P receptor blocker. And then we also have ofatumumab and ublituximab. These are anti-CD20 treatments, so anti-B cell treatments, which are like what we currently have in the form of Ocrevus or ocrelizumab, as well as off-label use of rituximab. One thing to note about these medicines is that ofatumumab will be given as a subcutaneous injection roughly once a month, whereas ublituximab is like rituximab and ocrelizumab, an IV infusion. And this is the timeline for MS disease-modifying therapies. From the beginning, 1993 is when we got our very first MS immunotherapy, and that was an interferon beta, beta-seron. And then over the years, we've gotten many more in various formulations, subcutaneous injections, IV therapies, and oral pills. And we've learned a lot about treating MS in that amount of time. I'll talk a little bit specifically about this class of S1P receptor blockers or modulators in multiple sclerosis. So again, these include fingolimod, ozanimod, ponesimod, and siponimod. Their S1P stands for sphingosine 1 phosphate receptors. These are actually receptors that are found all over the body. There are different flavors of them. There's subtype 1, 2, 3, 4, and 5. We think the subtype 1 is probably the most important in terms of what we do. Those are found on lymphocytes. So one of the well-known characteristics of treatment with this class of medications is that it blocks the exit of lymphocytes from the peripheral lymph tissue. So that results in those lymphocytes being trapped in those tissues and unable to gain access to the blood and subsequently the brain. In addition, we think that these medicines have direct effects on the brain. They can accumulate in the brain and target different brain cell types, including neurons and astrocytes and oligodendrocytes. Oligodendrocytes are the cell type that produces the myelin, and astrocytes have a very important role in MS and recovery from MS. One thing to note also about this slide is that whereas fingolimod or Gilenya targets these different receptor subtypes 1, 3, 4, and 5, the newer S1P receptor modulators, ozanimod and siponimod and ponesimod, are more selective in the different receptors that they target. And so could that have a differential effect? Maybe, maybe not. These are the results from 2 relapsing studies of ozanimod, and they were compared to interferon beta 1A, 30 micrograms, which is Avonex. And as you can see, in both studies, ozanimod was superior to Avonex in terms of reducing the relapse rate. And this is pretty similar to what we would expect to see from a medication of this class. In fact, fingolimod had a very similar study several years ago, which produced similar results in terms of relapse rate reduction. One of the reasons we talk about where these medications work, which cell types, is that the idea being that we know that our medicines all have an effect on the immune system, either eliminating certain immune cells or blocking their entry into the nervous system or blocking trafficking in some way. But one of the reasons we talk about some medications like these S1P receptor modulators having direct effects on different nervous system cells is that perhaps they might have some benefit in terms of progression delaying, something that even with our most potent immunosuppressants, we don't necessarily accomplish in all cases. And so to remind you, these were 2 progressive studies, one with siponimod in secondary progressive MS on the left, and one with fingolimod in primary progressive on the right. Siponimod was shown to have a modest benefit in terms of delaying progression in secondary progressive MS, whereas fingolimod's study in primary progressive MS showed no benefit whatsoever. And so the question is, are these medications really doing something different? Is the more selectivity of siponimod with respect to these S1P receptors really the thing that made a difference here? Or is it rather that we're getting better at designing clinical trials for progressive MS and being able to show these relatively mild benefits? So the difference between these 2 trials, besides one being in secondary and the other being in primary progressive, is that the siponimod trial enrolled far more patients. So when you enroll more patients, you're better able to show a very small effect. And in addition, a good quarter of the patients in the secondary progressive trial had active MRIs at the time of their enrollment, whereas something like 13% in the fingolimod study did. And we think that having evidence of disease activity in the form of active MRIs is very tightly linked to whether you're going to respond to any of these immunotherapies or not. And certainly having a quarter of the patients have active MRIs may be different from what we normally see in a secondary progressive clinic population. We also saw results of ofatumumab study. Again, this is going to be the new anti-B cell treatment like rituximab and ocrelizumab, but instead of being IV, this is given through a subcutaneous injection. And what we see from these studies in relapsing MS is what we come to expect from anti-B cell treatment in this population, which is to say a very significant reduction in the relapse rate on the left, and on the right, a near complete shutdown of active MRI lesions with treatment. In addition to these medications that we already discussed based on mechanisms of action that we're already familiar with, there are hopefully in the near future, we'll see some different mechanisms among our disease-modifying therapies. So these two medications that I'll talk about briefly work on by inhibiting different tyrosine kinases. These are enzymes that have an important role in cell signaling. So the first medication, masitinib, I believe that is how you pronounce it, is produced by a company, AB Science, and works at the level of macrophages and mast cells. They just released a press release in February that said that they had demonstrated positive results in a combination of primary and secondary progressive trial. So I haven't seen the details of this, but I'd be interested and be on the lookout for more information from this. The next medication doesn't even have a name yet, but it is produced by Sanofi and targeting a different tyrosine kinase, Bruton tyrosine kinase, or BTK, which works at the level of B cells as well as microglia. These are cells in the brain itself. They demonstrated a benefit in a relapsing MS study, and hopefully we will be working with them soon on further studies of this molecule in relapsing and progressive MS. It is not all good news, however. You may recall from a few years back, there was a study of high-dose biotin in progressive MS, in which it showed that there was a benefit compared to placebo, not just in terms of slowing progression, but actually suggesting that a small percentage of people actually improved compared to their baseline. This was back a few years ago. We then participated along with several other MS centers in this country to try to replicate in a clinical trial to try to replicate these findings. And unfortunately, the results turned out to be negative. The company that makes this high-dose biotin announced that the trial did not meet any of its primary or secondary endpoints. So if you're taking high-dose biotin currently for multiple sclerosis, you should probably stop. If you're taking a lower dose biotin for your hair and nails, then you can probably continue to do that. We do have one ongoing progressive trial that we're participating in, and it's for alpha lipoic acid at a high dose. And this is a randomized controlled trial, like many of our studies. And so half of the patients will receive placebo and the other half will receive the active medication. And our goal is to try to see whether this medication results in better endpoints, specifically based on walking and falling. So to be determined. I've had a lot of questions in recent months about metformin as a potential pro-myelination therapy. As far as I can tell, this is not based on any robust data in humans with MS, but rather based mostly on studies like these in mice, where you have on the left a study that showed that older mice who were given metformin had restoration of the ability of those cells, the oligodendrocytes, to produce myelin, like they produced myelin when they were younger. And on the right, you have a different mouse model of MS in which metformin was given to mice after they had been given lesions to suggest MS, and it showed some recovery from those lesions. So these are still very early studies, and we'll need to see more data in actual human beings with MS before we can say whether this has any room in among our treatments. So we still, even though we have over 15 medications for MS now, there's still not a general consensus around the country and around the world about how do we treat, which medications should we start with, which medications should we switch to, when should we discontinue. These are all open questions, and when we talk about MS treatment, we're generally talking about treatment over many years or even decades. We tend to favor a use of highly effective medication from the very beginning. And there have recently been some studies on large cohorts of MS patients from around the world that suggest that the way we are treating people is the right way, because when people are started very early in their disease course with highly effective treatment, they tend to go on to have less in the way of long-term disability and are less likely to convert to a progressive form of the disease. But in medical science, we believe that the highest form of evidence is gotten from randomized control studies. So there are 2 such randomized control studies ongoing around the country to try to evaluate the treatment strategies of either choosing one of the more modestly effective medications to start with, and then gradually increasing the level of efficacy if somebody demonstrates that they're having breakthrough disease, or starting at the very beginning with a highly effective medication and just proceeding from there. And so we are taking part in this one on the top, Deliver MS. In addition to discussion of the way these medications work and how effective they are, there's also, of course, the major consideration when we talk about treatments is the financial aspect. And even if you've and your neurologist have discussed which treatment is right for you and you finally made that determination, sometimes costs can be prohibitive. We know that all of these medications have gone up in price from the time they were originally introduced, especially the ones that were introduced in the 90s. They've seen their prices go up many-fold. This was a study that looked at the amount that Medicaid spent per enrollee for the various treatments, and it was looking specifically at what happened after the first introduction of a generic medication. This was a generic version of Copaxone or glutathione acetate. I believe that was 2015 or 2014. And what they found was that there was actually no change in how much Medicaid spent per enrollee despite the introduction of generics. However, this was based on data from a couple years back, and so potentially in the coming year or 2, we may see additional studies like this that now that we will hopefully have more in the way of generics and biosimilars. And this is a similar study showing the rising price that people pay for these medications. Now, of course, people don't necessarily, the patients don't necessarily pay for all of these huge prices out of pocket. Oftentimes these are done by third-party payers, and patients in many instances are able to get discounted drug or free drug directly through the drug manufacturer. I just wanted to mention a couple things about the expanded use of telemedicine. So you may have noticed that many of our visits these days, in fact, all of our visits have been over the past several weeks done through virtual video conferencing as opposed to in-person visits. And this seems to work out for many of you. I would like to refer to this tip sheet, which is available through the Rocky Mountain MS Center website. And if you would just take a moment in the days leading up to your next visit to review this tip sheet so we can have so everybody can have a successful telehealth experience. I think that would really be helpful. And that's really all I have for today. Thank you for listening, and I hope you have a very nice day. Bye-bye.